Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing new Australian guidelines for diabetes-related foot disease. The guidelines have been endorsed by 10 national peak bodies and are published as a summary in the Medical Journal of Australia. You can find a link to the guidelines in the description of this podcast. My two guests worked on the guidelines and are with me now. Associate Professor Pete Lazzarini is a conjoint Principal Research Fellow at Metro North Hospital and Health Service and Queensland University of Technology in Brisbane. He's a podiatrist by background and founded Australia's first diabetes foot disease research program. My other guest is Professor Stephen Twigg. Professor Twigg is a clinical academic and the Kellion Professor of Endocrinology and the Stan Clark Chair in Diabetes at the University of Sydney. Professor Twigg and Associate Professor Pete Lazzarini, thank you so much for joining me today.
Pleasure to be here, Sam. Thank you for the opportunity.
Thanks, Sam.
Associate Professor Lazzarini, I'll begin with you. Before we dive into the guidelines, let's start by talking about diabetes-related foot disease. How prevalent is this condition in Australia?
I may answer with a two-parter. The first part being estimates of the numbers of people we think are affected by diabetic foot disease nationally, but then finish with the second part about perhaps the more interesting comparisons in terms of the burden of disease compared to other conditions. We estimate there's around 400,000 Australians affected by some form of diabetic foot disease nationally. That's around 2% of all Australians. Most of those have diabetes-related peripheral neuropathy or peripheral arterial disease, which put them at risk of developing the more severe diabetic foot ulcers and infections. But we also know around 50,000 of those Australians have a diabetic foot ulcer each year. So around 50,000 Australians walking around today with an ulcer, and around half of those are infected at any one time. And that all results in around 30,000 hospitalisations caused by diabetic foot disease each year, which actually makes the leading cause of hospitalisations in Australia. And then 5,000 unfortunately have some form of amputation because of diabetic foot disease. 2/3 are minor amputations, which are like part foot amputations, and 1/3 is a major amputation or a leg amputation. Unfortunately, from our latest data, we've seen the trends in the leg amputations, which we're particularly worried about, declining in Australia with better care. I guess the second part, if I may, the answer is the more interesting, comparing that to other conditions. And we've done a number of studies now looking at the global burden of disease caused by diabetic foot disease compared to other conditions. And we now know relatively clearly that diabetic foot disease causes around 2% of the globe's disease burden in its entirety, which compared to other conditions, the other 350 leading conditions, makes it the 13th leading cause of the globe's disease burden. And to put that in perspective, that's about the size of the entire stroke disease burden or dementia and breast cancer combined when it comes to disease burden. So we sort of suggest that 2% of the globe's disease burden is caused by diabetic foot disease, which probably represents diabetic foot disease really nicely because 2% doesn't sound like much. Most people don't think diabetic foot disease is much, but when you extrapolate it across the country or the planet and compare it to other more well-known conditions with lesser burdens, it should be a big health problem or health policy driver. And we do know, though, that we need guideline-based care, and hence these guidelines, because we also know that we can reduce all those burdens of disease for patients, nations in the globe just by implementing what we already know works from the research, which is guideline-based care into those patients, regions and nations. We can reduce those burdens by half. And hence we need these new guidelines and to promote these new guidelines.
And let's discuss why you developed these new guidelines. Professor Twigg, the previous guidelines from 2011 were outdated. What clinical gaps did you see that prompted you to begin work on the guidelines?
So, reinforcing Pete's comment, firstly, practically developed clinical care guidelines that are up to date can really make a positive difference to healthcare outcomes. And in this case, for people with foot disease, we have quite a number of examples from underdeveloped countries which are developing healthcare systems, but also well-developed countries that implementing practical clinical care guidelines can lead to improvements in health. And so I'm the medical head of our high-risk foot service, specialist foot service in diabetes at RPA, and we've observed as well over the years that well-directed implemented guidelines are critical to underpinning quality care. And more specifically, to answer your question, there's a number of areas of the guidelines that have been, if you like, improved and updated compared with the ones from 2011. Some of the key changes include categorizing, having straightforward ways to identify if someone does have a wound or a foot ulcer in diabetes, which, by the way, is very common. Up to 1 in 3 people with diabetes will develop a foot ulcer. Ways to classify that, and that helps us understand then what might be their prognosis and also how we might be able to intervene to improve outcomes. So, for example, in the wound classification systems, Pete's mentioned neuropathy, nerve damage is very common, but whether clinical infection is present, for example, and the severity of the infection, if there's peripheral arterial disease and the severity of the PAD, these are very important issues which have a direct clinical impact on the likely outcome of healing of the ulcer in a timely manner and whether it will heal. But secondly, what are the appropriate interdisciplinary interventions and appropriate pathways, if you like, to improving outcomes? So the examples I've given you there relate to coordinated care, which is typically required for people who develop an acute problem such as a foot ulcer, and on average, it will often take 12 to 14 weeks for a foot ulcer to heal in someone who develops it with diabetes. And then all the discussion there is relevant in terms of helping assess risk as well for people who have diabetes, and what is their risk of a foot ulcer or that type of complication, how can we help prevent it? And so the clinical care intervention is both from the point of view of stratifying risk, help determining risk and help preventing an acute complication. Then if it does develop, to have appropriate evidence-based clinical care pathways to improve outcomes. So we have that good evidence from the literature, as Pete was saying, internationally in particular. We've got positive local experiences, but know that the field progresses, and most clinical care guidelines might have a life of, it used to be thought traditionally 5 years. What we're now experiencing in most areas in medicine and health is living guidelines, which are reviewed continuously and at least every 1 year if possible. So these were well overdue, very timely considering the burden of disease, and also that we have improved services in some ways and streamlined approaches across Australia to help manage these conditions.
And these guidelines are now published in summary form in the Medical Journal of Australia. Let's talk about the recommendations. You've made 98 recommendations for the medical community. Associate Professor Lazzarini, for people without diabetes foot-related disease, what are the key changes you recommend?
Yeah, so there is a lot of recommendations, as you've outlined, Sam. In terms of, I guess, the more straightforward recommendations, particularly for a GP sitting in practice, really what we want GPs to do, or the recommendations suggest, is for anyone with diabetes annually to be screening their feet for diabetes-related foot disease. As Steve said before, that's primarily looking for neuropathy with a 10-gram monofilament or even Ipswich touch test, or peripheral arterial disease via a history and also pulse palpation. Because that then leads on to, as Steve touched on before, the new risk classification system, the IWG risk classification system, which is different to the old guidelines. We've now got 4 risks compared to 3 and a few extra risk factors to look for as well. The 4 classifications are basically very low, moderate and high risk of developing a diabetic foot ulcer. Very low is those patients with diabetes who don't have any signs of peripheral neuropathy or peripheral arterial disease using the tests that I talked about before. Those that with peripheral arterial disease or neuropathy from those signs, then we want GPs to go on a step further, and also podiatrists and other people screening feet, and look for foot deformities such as claw toes, bunions, Charcot feet, which increase the risk of ulcers. End-stage renal failure as well, we've found increases the risk of developing ulcers. So the very low risk is those without neuropathy and arterial disease, should be screened every year. The low risk are those with arterial disease or neuropathy, screened every 6 months. Those with neuropathy and arterial disease plus a foot deformity should be moderate risk of ulcers and screened every around 3 months. And those, again, with a neuropathy, arterial disease, and then a history of ulcers, amputations, and end-stage renal disease every 1 to 3 months. They should be pretty much screened and managed. And in terms of management and education, we've made a few additional recommendations compared to 10 years ago as well. In terms of education for those patients, we encourage or recommend that patients should be informed of their risk classification level and what that means for the patient. Also, if they've got neuropathy, arterial disease or worse, to screen or check their feet daily for ulcers, pre-ulcerative lesions, which are basically like abundant callus, which we suggest is like, a lump when it comes to breast cancer. We're checking callus now in people with neuropathy because we know that will probably go on to lead to an ulcer, and educate about the appropriate footwear to prevent ulcers down the track. And then in terms of treatment, when we're talking about screening for those various risks, we're really looking again for treating those pre-ulcerative lesions using by debriding them, but also medical grade footwear. So those patients at high risk, particularly with a history of ulcers, we're now encouraging those patients or recommending for those patients they get medical grade footwear that offloads that old ulcer area to redistribute to the other areas.
And for people at increased risk of diabetes-related foot disease, Associate Professor Lazzarini, what do you recommend in this case?
For those who have neuropathy or arterial disease without foot deformities, history, etc., we're talking about education of patients so that they can check their feet every day, checking for pre-ulcerative lesions, ulcers, etc., and problems, and then wearing appropriate footwear that's not going to harm their foot at the end of the day. Those are particularly at high risk with ulcers, with a history of ulcers or amputations. As I touched on before, we're asking them we're recommending that they get medical grade footwear a lot of the times to prevent those ulcers, and that medical grade footwear is designed to try and relieve pressure from the old ulcer which caused it in the first place in patients with neuropathy. And we've found in trials now across the world that reduces the incidence of re-ulcerations by about half. And the other thing which is of interest to GPs in particular, I would imagine, and a new recommendation, this guideline, is in terms of activity. We used to say that patients with neuropathy or arterial disease would try to stay off your feet when you don't have an ulcer. We're now suggesting that we can gradually get back into more activity as long as it's gradual. This is in patients without an ulcer. It's gradual. And patients are wearing the most appropriate footwear and they're checking for any problems as they go along. So we can slowly increase their activity now, whereas we used to recommend not or try to reduce activity. And the other big recommendation was monitoring for skin temperatures because we know that any increase in skin temperature by about 2 degrees compared to the other foot typically is inflammation, which is a pre-ulcerative lesion leading to an ulcer. And if we can identify that early, we can hopefully prevent an ulcer. But unfortunately, we don't have those temperature sensing equipment in Australia as yet, but watch this space. So really, we've got education, we've got some treatments in terms of debriding, footwear, monitoring, etc., when it comes to those people at risk of developing ulcers.
And what about people with diabetes-related foot disease, Professor Twigg?
Yeah, well, thanks, Sam. That's, if you like, the next stage along the way from what Pete was describing. Someone, for example, if they develop a foot ulcer, then of course the concern is that we need to assess and manage that in a prompt manner and aid its healing and hopefully avoid the need for amputation or spreading of problems related to the ulcer, which might, for example, be infection. With an acute onset foot ulcer, it's very important to appreciate what are the factors that might have precipitated and predisposed to that ulcer, and then prompt referral, typically through to specialist foot care services that can provide the essential components, ingredients of different team members to help that ulcer heal. So, for example, in classifying a wound, a new onset ulcer, internationally there are more than 30 wound classification systems and it can be quite confusing. And thankfully, with the new guidelines, there's been a convergence and agreement in the field internationally and with these guidelines nationally that there's a standard system known as SINBAD, SINBAD, well validated, particularly in the UK, which in these guidelines we've adopted across Australia for foot ulcers in people with diabetes. And If you use Sinbad, then you won't sin bad. How about that? We need some form of catch cry that might get it out.
And how long do you think it will be until the guidelines can be implemented fully across Australia?
We're being realistic about this. We would not be surprised if it takes the best part of a decade for Sinbad to become second nature for medical practitioners, but it's quite simplistic. It's a score from 0 to 1 for each of those letters, and it's site, ischemia, neuropathy, bacterial infection, area of the ulcer, and depth. So some things about the ulcer and whether there's infection or PAD ischemia in particular. And Pete mentioned neuropathy. And the reason that's valuable to have that as a tool is it's a common language that we can use. If there's 0 or 1, we know that if the score is 4 up to 6, then that's in a much worse prognostic group. Most of the ulcers will be 0, 1 or 2 in a general practice setting, often 1 or 2. But on top of that, we can give the score, we can identify what are the key components, and we can communicate as healthcare professionals in a straightforward manner, but using a common lingo, if you like. For more complex scoring systems, there's severity of infection, a scoring system which has also been recommended in the guidelines for specialist services would be Wi-Fi, which describes the severity of the wound in a more nuanced grading, and if there is infection, mild, moderate, or severe, with typical descriptors, and then also if there is peripheral arterial disease, again, mild, moderate, or severe. And that has a much more nuanced approach to it in terms of identifying risk of amputation and chance of healing and having what's called ulcer-free days. We like to help ulcers heal and then prevent recurrence. There are a couple of examples, and then we could go into more detail about the grading systems for infection and within Wi-Fi, for example. But at the end of the day, it helps in the assessment, in the timely referral of the more complex ulcers, which are less likely to heal. We'd like all ulcers promptly referred, but particularly the ones that have the highest Sinbad score and the more complex pattern. And also what might be the ingredients that we can institute in that green finger approach, if you like, to getting these ulcers to heal. And it's a combination of usually treat infection, debridement and dressings, revascularization, and importantly, offloading, minimizing pressure, because most of the ulcers are under the feet and patients can't feel their feet well, and they can often have incredible pressure running through key points in their foot. And unless the pressure is minimized with appropriate devices, Pete was referring to, even in the absence of an ulcer, these offloading devices, how valuable they can be. So there are a few key pointers, Sam, I think. And the one other point I'd make is that these guidelines are Australian specific. They've been adapted from some international ones, 2019, but about 1/3 of the international ones needed adaptation. Some of them were excluded, and we put 35 health professional colleagues and people with lived experience on this task, and over more than 18 months to get these guidelines together. And Pete did the hard yakka and I did the waving, but essentially, but we got there. And just to demonstrate to you that adapting from international guidelines and trying to ensure that they are appropriate for care within Australia required an effort, but I think is well validated by the outcome.
And yes, let's talk a bit more about infection. You've included 35 recommendations about infection, like severity classifications, and 13 recommendations about wound healing. What are you guiding the medical community to do in terms of infection?
Infection is well described in the guidelines in the mild, moderate, and severe. I mean, it relates to the depth and extent of the wound in the foot, and also whether the patient's systemically unwell. Worthwhile just clarifying there that, the old rubor and dolor, the redness, swelling, heat, and pain. Patients with foot disease in diabetes will often not have pain, and if they have pain, then there may well be an abscess. So we can't always rely upon the standard signs and symptoms of infection as well. Sometimes you get an undermined wound or pus in the base, or it probes deeply. The standard redness, swelling and heat, very important, and two of those features to reflect inflammation of the site and usually some degree of infection that we need to get onto promptly. But if someone has significant ischemia and if they have dense neuropathy, we just had to have a good suspicion. And that's why, if unsure, prompt referral through to the specialist services. We're much more familiar in managing these conditions, and but certainly at a primary care level, that's where they'll initially show up.
And Associate Professor Lazzarini, what's the next step for these guidelines?
We need to get the message out, essentially, that the guidelines are there. The burden is huge, and if we use the guideline, we can reduce that burden at the end of the day. But we're quite aware that there's these guidelines. This is a guideline summary that we've published in MJA. There's actually 6 individual 50-page guidelines that sit behind these guidelines, which cover, as Steve said, prevention, screening and prevention, but then ulcer classification, infection management, peripheral arterial disease management, offloading management, and also wound healing interventions or dressing management at the end of the day. Developed by, as Steve said, 30-odd experts from around Australia following a systematic adaptation of the international guidelines. So it's a huge amount of work. Steve was very kind in terms of my contribution and not so kind in his own. But there's a huge amount of work that has been involved. So we want to get this out. And what we've also done is not just created this 300 pages of information and 100 recommendations. We've also distilled this with the National Diabetes Services Scheme's funds kindly provided into a toolkit, which is also available, which is a practical toolkit of about 20 pages with various pathways that incorporate all these recommendations, so clinicians can basically go from woe to go, or go to woe even, with their patient sitting in front of them to use these recommendations. And we've gone a step further, and we've now got digital pathways and nearly choose your own adventure pathways all up on the Diabetes Feet Australia website, where GPs or podiatrists or nurses or whoever with a patient with diabetic foot disease in front of them can click on these pathways to identify the recommendations that are required for that particular patient in front of them in terms of assessment, in terms of education, in terms of management. So we want to get the awareness out, but we're quite conscious that we want to make these as practical as possible to use, that they don't sit on shelves. So we've tried to develop a whole range of implementation tools to make it easier for clinicians to implement them in practice at the end of the day. I would just say, though, that as Steve touched on, the latest international guidelines are also out, of which we adapted the last iteration. And now the next big step for us as a diabetic foot community will be to adapt them, as Steve was talking about, again into the Australian context. But that will be at a later date. These are the Australian guidelines and the best standard of care for Australia at this point in time. And really we want people using them in GP practices, in other medical, allied health and nursing practices across Australia to reduce the burden of disease on patients, regions and nations at the end of the day by just using them.
Associate Professor Lazzarini and Professor Twigg, thank you both so much for joining me today.
You're welcome. Thanks, Sam.
Thanks, Sam. Much appreciated.
My special guests have been Associate Professor Pete Lazzarini, a conjoint Principal Research Fellow at Metro North Hospital and Health Service and QUT in Brisbane. He's a podiatrist by background. Professor Stephen Twigg is a clinical academic and the Kellion Professor of Endocrinology and Stan Clark Chair in Diabetes at the University of Sydney. You can read the guidelines in summary form by clicking the link in the description of this podcast. You can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for joining me.